This is Michelle Dreiling, and this is my presentation for nurse practitioner roles in primary care, discussing Carolyn Bupert's text, Nurse Practitioner's Business Practice and Legal Guide. We will be discussing Chapter 5, which is Prescribing. We will discuss an overview of nurse practitioners' roles in prescribing, as well as prescribing controlled substances and the Drug Enforcement Administration. And we will also talk about guidelines that nurse practitioners should follow when prescribing medications. Bupert acknowledges that prescriptive authority varies greatly between states. Words other than prescribe can also be used, including order, authorize, and direct. Prescriptive authority refers to the nurse practitioner's legal authority to prescribe medications. Nurse practitioners in 50 states and the District of Columbia have prescriptive authority. In 25 states, experienced nurse practitioners have explicit legal authority to prescribe and have no requirement for physician involvement. In 5 of these states, there is an initial period of 2 to 3 years after graduation that a nurse practitioner must complete a mentorship program. In those states, the mentorship program must be completed before obtaining full prescriptive authority. In 24 states, nurse practitioners have explicit legal authority to prescribe, but must be in a collaborative relationship with a certain physician. There is one state, and that is Utah, that nurse practitioners need physician involvement only when operating a pain clinic. The American Association of Nurse Practitioners recognize that the scope of practice for nurse practitioners does include prescribing. Prescriptive authority is regulated through state boards of nursing, which is why it varies so greatly from state to state on prescriptive authority. Here is a map provided by the Scope of Practice policy. This is an easy way to visualize the prescriptive authority and how it is variable throughout the states. The lightest color shows that there is physician relationship or collaboration required. The medium shade color shows the transition to full prescriptive authority, which can mean the mentorship program needs to be completed prior to full prescriptive authority. And the darkest color is full independent prescriptive authority. Now we will discuss controlled substances. Narcotics, depressants, stimulants, and hallucinogenic drugs are all covered under the Controlled Substances Act, which is the federal law. Nurse practitioners are allowed to prescribe controlled substances. And in 6 states, nurse practitioners must complete regular continuing education requirements. Those 6 states include California, Kentucky, Mississippi, Tennessee, Texas, and South Carolina. Every controlled substance has a certain classification. Both Bupert in the text and the United States Drug Enforcement Administration acknowledge the same aspects for classifications of controlled substances. There is 5 schedules of controlled substances that we will now review. Schedule 1 is the highest abuse potential and is not accepted for medical use in the United States. Schedule 1 drugs include heroin, LSD, ecstasy, MDMA. There is many, many more. Schedule 2 has high abuse potential with potentially severe psychic or physical dependence. Schedule 2 drugs include but are not limited to morphine, fentanyl, hydrocodone, Dilaudid, Demerol, oxycodone. A lot of those medications are used in inpatient hospital settings as well as outpatient settings for pain control. Schedule 3 controlled substances are stimulants and depressants with an abuse potential, but it is less than Schedule 1 or 2 drugs. These can include Tylenol with codeine, ketamine, and testosterone. Schedule 4 controlled substances have less abuse potential than Schedule 3. These can include alprazolam, Darvocet, Valium, Ambien, and Xanax. And lastly, Schedule 5 controlled substances have less abuse potential than Schedule 4 and consist of preparations containing limited quantities of narcotics. Typically, these are used in antidiarrheals, antitussive, and analgesic purposes. Examples of Schedule 5 drugs include Robitussin, which has less than 200 milligrams of codeine per 100 milliliters. Also Lomotil and Lyrica. The federal government, the Drug Enforcement Administration, or the DEA, oversees all nurse practitioners' prescribing of controlled substances. To prescribe controlled substances, a nurse practitioner has to register with the DEA and obtain a DEA number. The nurse practitioner must use the DEA number on all prescriptions for controlled substances or scheduled drugs. DEA registration is one method of tracking healthcare providers' prescribing practices related to controlled substances. The DEA number is also a method of minimizing unauthorized prescribing. For example, a person who is not authorized to prescribe but who wants to write a prescription for a controlled substance, someone has a prescription pad and signs the name of an authorized prescriber will be unable to get that prescription filled if it does not include the DEA number. Federal registration is based on the applicant's compliance with state and local laws. If a state requires a separate controlled substance license, the nurse practitioner must obtain that license and submit a copy with the application for a DEA number. If state law does not authorize nurse practitioners to prescribe controlled substances, the DEA will not issue a DEA number. Additionally, DEA registration costs $731 for a 3-year term, and states may individually charge for a registration fee on top of that. In the next several slides, we will discuss what Beaupert identifies as some general guidelines for prescribing legally. Prescribe the right medicine at the right time for the right indication and for the right patient. If there is a practice protocol or guideline in the facility that the nurse practitioner works in, it should be followed. If there is no facility-wide protocol, nurse practitioners should adhere to the standard of care in prescribing. The standard of care for prescribing may be assumed to be the physician's desk reference or Hippocrates for indication, dose, and side effects, and one of the state, agency, or organization guidelines for prescribing opioids for chronic pain. Some examples of guidelines for prescribing opioids are the Center for Disease Control Guideline, American Academy of Neurology, Opioids for Chronic Non-Cancer Pain, and Oklahoma Opioid Prescribing Guidelines. Before prescribing a medication, a nurse practitioner should ask a number of questions. Are you pregnant? Are you trying to be? Are you breastfeeding? Are you allergic to any medications? Have you taken this medication before? Did it work? Did it give you any ill effects? Do you have any liver or kidney problems? What other medications are you on? What other medical problems do you have? Before prescribing an opioid or other controlled drug, ask additional questions to assess the patient's need and current function to determine whether a patient is at high risk for abuse. Among these questions, you can ask, what number from 0 to 10 best describes your pain in the past week? What number from 0 to 10 describes how, during the past week, pain has interfered with your enjoyment of life? What number from 0 to 10 describes how, during the past week, pain has interfered with your general activity? Evaluate the patient's underlying condition to determine the need for medication of pain. How often in the past 5 years have you taken pain medication? What did you take? How often have you taken a non-steroidal medication for this pain? How effective is it? Have you tried to decrease your pain through any means other than medications? In the past, have you taken any medications or drugs that are not prescribed specifically for you? Are you willing to sign a contract in which you agree to get prescriptions from only me to give you 72 hours notice before you need a refill? To consent and to undergo random urine screens and to use only one pharmacy? To assess risk of abuse, utilize the opioid risk tool available online. Check the State Prescription Drug Monitoring Program database to see whether the patient is registered there and to determine what medications, if any, he or she has been getting from other providers. Before prescribing an opioid medication, perform a urine drug screen to determine whether the patient has controlled drugs in his or her system. Address any cross-sensitivities. For example, if a patient is allergic to penicillin, a nurse practitioner probably should not prescribe Keflex, which has cross sensitivities with penicillin. Address any contraindications. For example, a patient with chronic hepatitis should not be prescribed a medication that has potential for liver damage unless it is a life or death situation and there is no other choice. Address any drug interactions. Inform the patient of potential side effects and ask whether the patient wants to accept the risk of experiencing those side effects. And lastly, instruct the patient to call or return if he or she notices any adverse change in his or her condition. Buper also identifies other considerations that nurse practitioners should take into account when prescribing medications. Can the patient afford the medication? Is the drug to be prescribed in the formulary for the agency or health maintenance organization? Is there potential for abuse of the medication? For example, a depressed patient may overdose on a prescribed medication, and a patient with a history of substance abuse may be seeking to continue the habit. Can the patient read? Do they have any vision problems? There are many things to consider when a nurse practitioner prescribes a medication. Here is a list of my references, and that concludes this presentation on Chapter 5, Prescribing. I welcome any questions, concerns, and comments. Thank you.